Dr. McCarthy, Captain Graf, can you hear me?
Yes, sir.
Are y'all there? Okay, awesome. So I'm just gonna introduce you to everyone, if that's okay. Today we have Dr. Patrick McCarthy. He is a captain in the U.S. Army Medical Corps, PGY-3 General Surgeon Resident at Brooke Army Medical Center in San Antonio, and he's a current research fellow with the Cancer Vaccine Development Group. He earned his Bachelor of Science in Biochemistry and Cell Biology from Rice University and his medical degree from the Uniformed Services University of the Health Sciences. After residency, he plans to specialize in trauma surgery and critical care or surgical oncology. Dr. McCarthy is passionate about teaching austere battlefield surgery and basic science oncology. He is currently serving as a member of the Eastern Association for the Surgery of Trauma Burn Committee. Dr. McCarthy, thank you so much for joining us today.
Thanks for having me, guys. I appreciate it.
Of course, of course. So how has your day been so far?
It's been good. Funny you should ask. I just got off a meeting for the Burn Surgery Committee, and we were talking about different things, how to improve outreach and some of the other research projects we've got going on. But otherwise, I'm living the life of a research resident, which is pretty nice, not in the hospital constantly, and a nice break.
That's awesome. That's awesome. So like seeing your credentials and everything, you're super decorated in a lot of ways, and it's very cool. So just tell us a little bit about yourself and what got you interested in your career path.
Thanks. Yeah. So I grew up with my dad. He was a military physician. He was in the Navy, and so I got a look into military medicine from that perspective. He ended up doing radiology, and I was around when he was going through his training for that. And then I got kind of my first look into the military side of things. Actually, when I was in high school, I had the chance to work at a research facility called USAMRIID, which specializes in infectious disease and bioweapons defense. And if you've read the book Hot Zone, it's very popular because of that. And then they've done different types of things with other pandemic type research. They were involved in Ebola when that happened in Africa, and they're involved with COVID now. And so I got my first look into military and biosciences and military sciences through that. I ended up going to Rice and really enjoyed it. I thought I wanted to do biomedical engineering, and then kind of backed off of that because I'm really bad at computer programming, honestly. It is not my thing. So kudos to all you guys who do that. But at the same time, I got involved in EMS down in Rice and in Houston. In Houston, Rice is right next to our medical center, and Houston is one of the biggest medical centers in the country. And I got a really great look into pre-hospital medicine and emergency medicine, and realized I really liked it. I got the chance to do real medical care on real people before I was ever in medical school. So I was giving medications, starting IVs, doing CPR, running codes and stuff, and in the hospital and out of the hospital. And that's where I really decided medicine was something I really wanted to go after. And then kind of towards the end of undergraduate, I had to make a decision if I wanted to continue down a pre-hospital pathway. I actually applied for and got a job offer to work as a paramedic, or go the medical school route. And I ended up choosing the medical school route.
That's insane. That's actually a lot. So could you tell us more about your path to becoming a PGY-3 General Surgeon Resident? And what exactly is a PGY-3? What is that?
Yeah, good question. So PGY-3 is an acronym that stands for postgraduate year. And so anybody who's in residency, which is essentially your specialty training. So there's specialty training for pediatrics, for surgery, for pathology, radiology, family medicine, dermatology. All these things have residency programs to make you not just a doctor, an MD or a DO, but a specialty trained doctor. And so the PGY is how many years after your medical school graduation are you? It gets a little confusing because, like me, I'm a PGY-3, but I've only spent 2 years in the hospital. And so you may come across two acronyms. The PGY is how many years after medical school you graduated. So this is my third year after I graduated medical school. But technically, I'm an R2. So the R designation is for how many clinical years you've spent. Surgery is a little interesting, as are some of the other surgical specialties and surgical residencies, in that you can take more than 1 year to go do residency, or you could spend no years doing residency. And so for surgery, there's people on the civilian side who take 3 years to do research. And so they may be a PGY-5, but they're only an R2. And so it gives you an idea of how long it's been since I graduated medical school, and then how many years have I spent in the hospital training. General surgery requires 5 clinical years, so you have to be an R5 in order to graduate. But you could be a PGY-5, you could be a PGY-7 or 8. In my case, the military requires a research year, and so I'll graduate as a PGY-6, but an R5.
I see. I see. Could you run us through a typical day in your life?
Yeah, I'll focus on my clinical days because the research stuff is it's kind of separate. But on a clinical day, I end up waking up pretty early. It depends on what team I'm on and what rotation I'm doing, and that changes about every month. But I'm usually waking up before 5 a.m. and trying to get to the hospital around an hour before rounds start. And rounds is just the team getting together, going around and seeing all the patients that are admitted to the hospital that you are taking care of. And that's pretty typical for most of the teams. And then once rounds are over, depending on which hospital I'm working at, there's usually some type of academic conference that happens. And it's probably around 30 minutes, but a discussion of some topic that's been advertised and discussed, and that you get questions asked, and you can ask questions, and a case is presented or a topic is presented. After that, it usually depends on the day. And so there's some days that are primarily spent in the operating room. There's some days where it's devoted to just clinic. And so on an operating day, the cases usually start at a pretty particular time. I've met the patients, checked them into the hospital, said, yep, everything looks good for surgery. And then I'll meet them in the OR and we'll conduct the case. And typically there's more than one case, and that just kind of goes till that's done. And at the end of the day, you finish up your notes, you go around on your patients again, you do whatever needs to be done. On clinic days, they're usually pretty full, and you're just in clinic seeing patients every 15, 30 minutes coming into the door that either they've been seen by a surgeon before and you're seeing them as a follow-up appointment, or this could be somebody who has never seen a surgeon and they're there to see you in order to get an opinion or to try and schedule a surgery or to get a diagnosis. So surgeons and in surgery residency, we have kind of a varied day to day, but in general, it's either operating room or clinic. And on pretty much every rotation, except for say an intensive care unit or some of the more specialized things like our transplant rotation, things like that. That's kind of how it goes. Some of the other rotations, you may be just doing kind of a separate schedule.
I see. So do you do your, so you said like, this is your typical day in the clinical setting. So do you also have, how many days do you dedicate to a clinical setting and how many days do you dedicate to like research?
It's not so much a day-to-day thing. The military will have you do, at least at our program, and the timing's a little different at each program, but the first 2 years we do our clinical, and generally I'm working 6 days a week, and the cap is 80 hours a week. So I'm required by law to not work more than 80 hours a week unless there's some type of special extenuating circumstance. And usually we're pretty close to hitting that or going over it. And then between my PGY-3 year is a research year. So currently I kind of wake up when I want and I do the research I want. And I'm mostly doing that from home. And that's typically how it goes. There are options on your research year to do other things like travel and take vacations that maybe you wouldn't be able to do when you're working 6 days a week. COVID's kind of changed that, unfortunately, and it's prevented us from doing a lot of the travel for conferences to present our research. But that's obviously not the norm for most people who have done this. It's once in a hopefully century type thing.
That's awesome.
Alrighty, Dr. McCarthy. My name is Garrett Johnson. I'm part of this committee as well. I'm a junior pre-med student, and we're all kind of wondering what inspired you personally to be a physician versus, another medical profession like a PA or a nurse or a dentist, particularly in reference to military medicine. I know with military medicine, extra coursework is required through the Armed Forces Medical School because in a lot of like say battlefield situations or foreign situations, you have to be kind of a jack of all trades. And was that particularly interesting to you?
Great question, Garrett. I kind of like I touched on previously, I had a little bit of an idea what military medicine would be like watching my dad go through the process. And he actually went to the same medical school. He went to USIS, and I got that perspective pretty early on. But like I said, it came down to a moment where I had a job offer to go work, and I would have made more money than I'm currently making to go. I would be working as an EMT and then paid to go to paramedic school and fire school. And I also had an application into USIS, and I hadn't quite heard back at the time. And so I had to make a decision: do I want to go to medical school, or do I want to go get paid a lot of money to do this stuff I know I already like? And what it really came down to for me was I knew in my heart I wanted to be a physician. I was attracted to that being kind of like the end pathway in my mind. And the physicians I had worked with were the leaders in medical education as well, which also appealed to me. I'd done a lot of teaching in my EMS duties, and I knew I enjoyed that. And then the military offered some of that pre-hospital, austere, battlefield type medicine as just part of being a physician. And that's not necessarily the case with being a civilian doctor or a non-military physician. And that's something I knew I liked. I actually had the opportunity to take a course in tactical medicine, kind of on the civilian side. So the medical support of SWAT teams, FBI hostage rescue, had a couple guys out. The U.S. Marshals have guys that go serve high-risk warrants. They all came out to take this course, and I got the chance to go do that. I got tased, I got pepper spray, or I got tear gassed. We did a bunch of stuff with simunition rounds and entering a building with an active shooter response, and how do you secure the building, move people out. And that's not necessarily the military perspective, but it was a look at tactical medicine. And that's something that if you're in the military, you have to have some familiarity with. Surgery from my end is very much involved in that, as are emergency medicine and anesthesia to a certain extent. But some other ones, maybe not so much. So infectious disease, you don't need to know how to go into a gunfight and do all these things. You have to be familiar with it because there's always that chance that that could happen to you if you are deployed. But that's not really their focus per se. And that's not to say that I wouldn't have enjoyed being a paramedic or doing something like a physician assistant or a nurse. It was just, for me, I felt like I wanted to be in the physician role. I wanted to have the control over a team. I thought they were able to provide a lot of education, and they were the subject matter experts when it really came down to it.
Thank you. And like as you said, as a team leader per se, is there a high likelihood of you getting deployed, say, to a war zone down the road as a general surgeon?
It's almost guaranteed. It always depends on what conflicts we're in and where they need us. But the current position of the Army Medical Corps is that we usually have surgeons kind of pre-stationed in areas that could be called in quickly to a combat zone. There's a couple active ones, but we typically send surgeons out to Africa where these little smaller skirmishes are happening that aren't well publicized. But you kind of get people who are injured, and they're injured and they need a surgeon. And so one of the things that attracted me to surgery was that aspect. Was if somebody's injured from a trauma perspective, really the person to fix it is a surgeon. You need to, most of the times, kind of cut into somebody and stop the bleeding or repair the damage or temporize the damage until they can get somewhere with better medical care. And so the medical corps has pushed surgeons very far out towards what we call the point of injury, or where somebody actually steps on the explosive device or takes fragment from a grenade or gets a gunshot wound. From our residency program, it seems to happen about every other year, but somebody typically ends up going to a active combat zone or very close to one about every other year straight out of residency. So you kind of finish your training, and within a month or 4 months, you're in Iraq or Syria, Afghanistan, Africa, all these places where we're seeing active engagements.
Thank you.
Yeah.
So kind of to build on top of that, what further inspired you to go into surgery?
Surgery for me, I thought I wanted to do emergency medicine. Coming out of my EMS background and thinking I was maybe going to be a paramedic, I was very interested in emergency medicine and kind of changed course halfway through medical school. And what it came down to me was kind of like you may have picked up. I'm very interested in the trauma side of things and the trauma support of the warfighter. And emergency medicine are our partners in doing that. But in order to really fix somebody, they generally need a surgeon. And so I learned that the surgeons were the ones who were kind of the definitive care. They were the subject matter expert in trauma. And emergency medicine is very much our partner in that, and they can help. But when somebody's injured deep down in their belly, it's a surgeon who handles that. In emergency medicine, not so much. The other aspect of it was I really liked being in the operating room. And so, for most of you who are probably going to go into medicine in some aspect, you may hear the advice that I got, which was if you want to go into medicine, you better not like anything else or some variant of that. Essentially saying that if you're going to be happy doing anything but medicine, you should really consider that as a career because medicine is taxing. There's a lot of discussion now about burnout and people who have a lot of delayed gratification by going into medicine. And it was the same thing with surgery. I really liked being in the OR and I wouldn't have been happy doing anything else.
Dr. McCarthy. So I'm currently a pre-med student. I'm on my junior year right now, and I have been on and off considering, joining the military as a physician. However, I've heard a lot of differing opinions. So for all of us who want to or who are considering this pathway, what would you have to say? What was your inspiration to join the military as a physician?
My motivation was very much a call to duty. I There's a lot of people who have that same sense of duty to go and serve in some aspect, and I knew I liked medicine, and I thought I was pretty good at it, and so that was my pathway. That being said, if you're interested in doing medicine in the military, there's great options to do that and get paid what I think is very reasonably well for it. There's really kind of three pathways, and people do it for the financial aspect as well, and that's kind of why I mention it. You have to be willing to serve, and in some specialties, you have to be willing to deploy more so than others. But you can go to USIS, which is kind of like a service academy for the military. It's kind of like the West Point of medical schools. Or you can do what's more kind of like ROTC for medical school, where you get into Baylor Medical or UT Southwestern or UT Houston on your own, and the military will pay your salary or will pay your tuition, give you some extra money to kind of defray the cost of living and books and stuff like that, and then you owe time afterwards. And then the other option, which people do, but it doesn't really cover the cost of education, is they go do medical school, they go do residency all on their own, and then they decide, hey, I want to serve. And that's actually, believe it or not, fairly common on the surgical side of things because that trauma aspect is something you can't get and you usually won't see here in the United States. Those injury patterns just don't exist, for thankfully. And so my real pathway was I knew I wanted to serve, and medicine was the best way for me to do that.
Thank you so much, sir.
Dr. McCarthy, so with those different routes, we sort of already talked about what motivated you to go into the military specifically and what brought you down the path of going to the Armed Forces Medical School versus doing, like you referred to, the ROTC program or comparable ROTC program. I know the Navy has a program very similar to what you're describing. On the tail end, you owe 4 years afterwards. So with the route that you took, how much time do you owe on the back end to the military? Do you owe them, 4 years, 5 years? Is it contractual variance for different doctors? And thus far, with your time in the military, what has been, do you think, your greatest achievement?
I'll touch on the the service requirement aspect first, and I'll let Captain Graff fill in what I get wrong or don't mention, and then I'll kind of come back to the greatest achievement part. So the two ways to get medical school paid for straight up are the Service Academy approach, which is the Armed Forces Medical College, and the name of the school is USIS or USU. That's the Uniformed Services University. It's a school on a military base just outside of DC, and you go, you wear a uniform for 4 years, you get paid as an officer, and then I will owe 7 years once I finish my residency training. So I still have 3 more years to finish being doing my general surgery training, and then I'll owe 7 years in the military after that. The other route is the Health Professions Scholarship Program. And like you mentioned, there is a program for the Navy, the Army, the Air Force. The USIS school has all those students mixed in, kind of a bunch in each class, and then something called the Professional Health Services as well. But there's a way to do it in any service. And the Army, I believe, is still, you go and you do medical school for 4 years, and then you owe 5 years of service, again, once you finish your specialty training, whatever that is. Currently, and I don't think this has changed, but I don't owe, you can think of it in 2 ways. You can think of it as I'm paying off the time I owe for medical school while I'm in residency, but then I'm also picking up time while I'm in residency. Or I think the easier way is I just don't owe any extra time while I'm in residency and I pay back medical school at the end. There's a bunch of terms that go into this and the actual contractual obligation and how it's written out, but that's how I conceptualize it. And same type of deal with the HPSP program. You owe that, it's the same kind of thing. You're either paying off while you're in residency and you do it, you're picking up time while you pay it off, or it just kind of goes on hold and you pay it off after. It gets a little tricky for some specialties and things are kind of changing. And as none of you guys are in medical school, I won't go too deep into this. But for some specialties like general surgery, where the military has come to realize that we need a lot of general surgeons because we are kind of the subject matter experts in trauma, they're starting to offer training programs outside of military hospitals for general surgery. And how you pay back that time is a little bit different if you're doing the residency program in the military like I am at an Army hospital, or whether you're doing it at UT Houston, where there's residents that are in the same kind of military pipeline that I am. Captain Graff, do you have anything to add or clarify on that?
No, I think you covered it pretty well. I don't think you got anything wrong, so thank you.
Thanks. And then as far as the personal achievement thing, tough question. I still have a long road to go, but I think probably the coolest thing that made me feel really fulfilled in my pathway, I'll kind of approach it from that perspective, was there was a patient that was a trauma patient, had come to our hospital. He had been in a motorcycle collision and came in not great shape. He actually arrived without a beating heart, which when that happens in the trauma setting, and it happens within a certain time frame of actually arriving at the emergency room, you get what's called a resuscitative thoracotomy or an emergency department thoracotomy, where you make an incision on the left side of your body, kind of on the opposite side of the sternum, all the way down to the table through your rib cage to get to your heart, to get to your aorta. And we actually kind of take the heart out of its protective sac and squeeze on it with our hands to start pumping blood around the rest of the body. So he was in bad shape when he had first come in, and that procedure was done. And then in addition to that, he had a what we called an atlanto-occipital dissociation. So that's basically saying that the spot where the back of his spine or the top of his spine connected to the base of his skull was really not connected anymore. He had kind of suffered an internal decapitation, is what we say. And he was not in great shape when he first came in. I met him because he was still alive. He was on the trauma service, admitted to the hospital, recovering, dealing with a couple of broken bones and stuff. And I wasn't there when he first came in, and he really wanted to meet the people who had saved his life, because he kind of understood once he woke up with this massive scar on his chest that something had really happened to him. And I was able to get a hold of those two surgeons. It was two young female residents, actually. One was an intern, so in her first year out of medical school, and the other was a second year. So she was a PGY-2 and an R2. And at the time, there was a kind of staff physician on the emergency medicine side down in the room, but the staff surgeon on call actually wasn't able to be down in the room when the patient came in because there was a different emergency in the operating room. And so those two surgery residents did a lot of that kind of on their own and ended up saving that guy's life. And it gives you perspective, and that it wasn't my own personal achievement, but it gave me a lot of pride and fulfillment in kind of the role I was fulfilling as a surgery resident.
That's really incredible. So you said he was in a motorcycle accident when he came in?
He had been in a motorcycle accident. He was kind of talking to them and he was breathing on his own, and then either because of blood loss or pressure building within the chest, he started to lose pulses. So at some point in the transport from where he had his motorcycle collision to arriving in the emergency room, his heart had stopped beating. And the way we generally fix that, as like I said, if it's within a certain time window of you arriving in the emergency room, is that big open incision. There was a time, there was a similar case, it was a young female who had been shot a couple of times in the chest. And we ended up doing kind of an extension of that incision. It's called a clamshell thoracotomy. And that one doesn't get done as often, but you kind of extend the incision from, you're making it this way over to the left side of the chest. You then just continue the incision all the way over to the right side, and you kind of open the chest like a clamshell. And that gives you exposure to both areas of the chest and the heart and the vessels that run up high off the aorta to stop bleeding, to fix a laceration to the lungs, to sew up any holes in the heart that you can. And I got to see her do that a couple of times. And in that particular one, one of the things we do at BAMC, at Brooke Army Medical Center where I'm stationed, is we use whole blood a whole lot. So traditionally, if you were to get a blood transfusion, you would get some component of what's in all of us right now. Red blood cells, plasma, which is kind of just the fluid that circulates things, or platelets, which are more so for the clotting aspect. And the red blood cells are more so for carrying oxygen to our tissues. The trauma surgeon at the time, and I was able to help, actually snipped off a corner of the heart close to where the veins insert on the heart, and took the tubing that was delivering the blood, which we weren't able to actually get an IV because she didn't really have a blood pressure at the time, took the tubing and then just stuck it and sewed it directly into the hole in the heart, so that you just basically are putting blood directly into the pump, and from the pump it goes to the rest of the body. And that was a pretty cool moment as well.
Those are really amazing stories. As pre-meds, we hear that and we hope we can rise to the occasion one day for that. But, sitting here in undergrad, it's pretty hard to imagine what those situations are supposed to be like, even just to witness. So thank you.
Yeah, it's a long ways off, but you guys will be there before you know it.
So going through all of this and residency, what would you say like your hardest experience in residency was?
The hardest experience of residency so far would probably be dealing with patients who you do all these things on and you try really hard. You've put in real sweat. We usually keep our operating rooms pretty hot, so it's not just a term. Like, we are sweating when we're doing these surgeries, and you can get a lot of emotional investment in trying to help somebody, and that could be the prolonged care of somebody with cancer, and you're doing multiple surgeries and coordinating their chemotherapy and radiation therapy, and they finally succumb to the disease or something else, or trauma patients who come in and we do all these things, opening their chest and otherwise pretty gruesome manners and we're cutting into somebody to try and save their life, and then it doesn't work. That's tough to deal with. And kind of we're balancing out the real highs of surgery now with the real lows, but that was something that was told to me again before I went into medicine, and then again before I went into surgery, was that this career will give you the highest highs and the lowest lows you'll have in your entire life, probably. And especially in the military, if you're involved in downrange combat care, you see things that just don't happen for good reason. A lot of times in the civilian setting, we don't deal with a lot of bomb trauma or improvised explosive devices, and building collapses, and a lot of stuff that does happen downrange. And that's kind of ahead in my future, but for the meantime, I would say that's probably been the most difficult thing, is really investing so much to try and help somebody. And you always want the person to live, and that may not actually be the goal. A lot of times it's to just reduce suffering, but it still is tough either way.
Yeah, thank you so much.
Dr. McCarthy, can you tell us about your work as a researcher in the cancer vaccine development group? What has that been like?
Sure. The Cancer Vaccine Development Group is it's a couple different organizations that are working together, and most of them are led by a surgical oncologist who's retired from the military. And what they do is they partner with pharmaceutical agencies and bioresearch groups who have developed or want to develop products to try and decrease cancer recurrence. That's kind of the state of the science. And so these could be proteins, these could be entire cells, and we call them vaccines. And that's not so much kind of like the COVID vaccine that prevents you from getting it, but it's designed to try and manipulate the immune system to prevent cancer recurrence. So the prevailing theory, and something that's become very popular in the last 10 years, is that all of us sitting here have cells that are cancerous. It's happening every day, every moment. Something is going wrong with our cell replication and growth, but the immune system in our bodies, being younger individuals generally, can recognize it and prevent it from growing into a tumor, which is really just a collection of cells that have gone haywire. And so how do we take the immune system for people who have developed cancer and turn it back on the tumor itself, either to make the original tumor disappear, which isn't so much happening, although it actually is for some diseases like melanoma, but to give the immune system a pattern to recognize to prevent the tumor from coming back after we treat it with chemotherapy, radiation, and surgery. And so that's where I've spent a lot of my time doing research. I'm involved with analyzing the data from clinical trials, writing protocols to run clinical trials, submitting them to our hospitals so that they can get approved and we can do the clinical trials. And then I do some trauma research as well, because I'm kind of interested in both fields.
What got you interested exactly in oncological research? Like, why was that the preferred one? It's very interesting how many people have. This is my first time hearing about these vaccinations for prevention. So, how extensively researched is it?
So I guess I got into it and was kind of attracted to surgical oncology because, I didn't end up doing bioengineering, but this was kind of like all the things I liked about bioengineering without ever having to do computer programming, which is great because, like I said, I'm really bad at it. And so I was able to do the biochemistry and the immunology and a lot of the basic science stuff. And that was the point that really intersected with oncology from a surgical perspective. And I liked that the surgeries involved in cancer surgery they're usually pretty complex. The patients are sick, but they're not like acute, generally not acute trauma sick, but they're sick in a lot of other ways. And while I would kind of liken, I used to play rugby. And so I think about trauma surgery as kind of being in the moment, you're really aggressively going kind of one-on-one with somebody, you're tackling them, and it's just blow after blow after blow. Whereas I liken cancer surgery to a lot more like chess. There's much more planning, there's much more timing things and making sure it all comes out. And they can both be very technically intricate, which I liked as well. And then how much is it researched? There's only one cancer vaccine that's been approved by the FDA to be used in patients not in a research setting. That's for prostate cancer, and prostate cancer is mostly handled by a separate residency. Those are urologists. They work on the kidney, the bladder, the ureters, which is the connection between the two. But there's been a lot of research into breast cancer vaccines and melanoma cancer vaccines, because those are both very prevalent, and they're cancers that seem to respond to immune system manipulation. One of the biggest breakthroughs we've had in cancer treatment, aside from kind of breaking down breast cancer into different types based off of cellular markers they express, but in melanoma, they've developed a drug and now a series of drugs where it's able to target a specific receptor on melanoma cells that the cancer cells use to evade the immune system and grow prolifically. And they've actually administered this drug just by chance. I was doing a lab in I was doing a heart-lung bypass type lab, and I met somebody who gave the first dose of that drug called Keytruda, and they were talking about how they gave it to a melanoma patient who had a tumor kind of growing and filling the entire gap between his ear and his shoulder. And within 2 doses of the drug, his cancer had disappeared. It had completely erased it. The immune system was totally flipped and able to fight it. And yeah, now that's not everybody, right? But that would definitely get a lot of people's attention. If you can give an injection, you can give a drug and not cure cancer, but you can make somebody's tumor shrink like that. That's pretty cool. And so there's still a lot of work to be done, and the vaccine side of it is not as well accomplished as the chemotherapy immune drug side of it. But the answer to cancer will probably be an intersection of all of these different fields: chemotherapy, radiation, vaccines, and immune therapy drugs.
That's very interesting. Thank you so much.
Yeah.
Does anyone else have any questions for Dr. McCarthy? Feel free.
I have a question. Dr. McCarthy, I was wondering about, so you talked about how you're sort of required to do research in some capacity, but are there military doctors that continue to do research, and do you know anything about that experience, and would you considering to do research in the future as a physician?
Yeah, absolutely. Great question. So research isn't just confined to 1 year. And I would say that research, to a certain extent, probably happens more regularly outside the military. The civilian world allows you to kind of take a break and go do research as much as you want. And I have colleagues who are kind of down the road at our civilian trauma partner that are taking 3 years to go down to the National Institute of Health and do research, and then they're going to come back. Or maybe they just get out entirely and they say, surgery's not for me. I'm just going to be a doctor that does a bunch of research. And so in the military, though, research it's not required, but it's something that you can definitely continue doing. And it's something that I will continue doing. We have a bunch of physicians that I work with that are doing different kinds of research outside of this cancer vaccine development program that I'm a part of. And that could be assisting with running those clinical trials. It's been looking at large databases to try and answer questions or come up with new ideas on how to treat things. And on the trauma side of things, we get not really solicitations, but we get requests from different people who have developed devices or products that they want to see if they really work. And the military's done a lot of stuff at trying to standardize that research, because a lot of that stuff kind of comes through our house. So one of those is, if you're familiar with QuickClot or C-LOX or combat gauze, or they're called novel hemostatic agents essentially, but they're these products that are like gauze that you can put on something to stop bleeding. but they actually have a chemical built into them that interacts with the blood and the clotting cascade to slow or to accelerate that clotting process. And we have a group that developed a product that is something they think can beat the industry standard with combat gauze or CLOX, both of which are issued to combat troops, and we use fairly often in the trauma bay and stuff. But they want us to evaluate it in a standardized way to give them an objective point of view of this is something that would work better or as good as the existing product. So to circle back to your original question, research is something that you can definitely continue doing, and I plan to continue doing as well.
That is really, really awesome. Thank you for that answer.
You're welcome.
Any other further questions?
Hi, Dr. McCarthy. My impression of like trauma is like you'd be like super stressed because you're different patient, different sort of the injuries that comes into like the ER. Like, how did you train yourself to be like stay in a calm position to go through like all these different scenarios in your head? Like, how would you stay calm and collective?
Great question. I was fortunate to have my EMT background, and I would actually say that's probably the biggest thing I've relied on, is because it's a lot different treating somebody in their home and their family members are right there and everything's different than when you come into a more controlled environment with people who kind of have all been assigned a task prior to the patient rolling in, and kind of almost going through an algorithm. And so part of the way that we help everybody stay organized is clear assignment of roles and running through an algorithm. And there's different courses. The biggest one is Advanced Trauma Life Support, that will teach you what order do you want to treat the patient in? Do you want to address their airway first? Do you want to address giving them blood first? Do you want to fix the hole in their chest first so that they can breathe better? And there's a certain way to do that. But in terms of the chaos, just managing people and yelling and getting freaked out, the biggest thing is to remember that you have to stay calm because nobody else will. And as trauma surgeons, when you're the head person in the room, everybody kind of looks to you. And that can be intimidating, and it doesn't always go super well. But that's something that gives me focus, is realizing that this is where I want to be, and everybody's looking to the trauma surgeons, not necessarily the resident, but the trauma surgery team to lead the care. And then the other thing is doing it a lot and getting comfortable with that. It's not a comfortable place to be. It's not a natural place to be. And as you mentioned, it's stressful, and that's not, the typical state of a human being is to be in a high stress position. And so I would say doing it multiple times and getting more comfortable just through exposure would probably be the biggest thing.
Thank you so much, Dr. McCarthy.
Anyone have any other questions? Further questions?
I have a quick question for all of our, especially younger pre-meds here. We're kind of curious, what were you like in undergrad? What was your typical day-to-day as, freshman, sophomore pre-med? And, what hobbies and things have you done to sort of keep up the pace and prevent burnout throughout this long journey?
Oh, man. So I think I mentioned it. I played rugby when I was in college. That was a lot of fun. That was a great way to stay active and physical. And then I did EMS as well. And for a variety of reasons, those groups didn't really get along. And so I was kind of this weird crossover between the two. But that's primarily where I spent a lot of my time, between that and classes. I also took a bunch of other classes that had nothing to do with medicine. I took game theory. I took an economics course and like a analytic literature course. I tried to take a language course, but the duties I had for EMS, they didn't want me in the class actually, because I would be on duty for 12 hours a day and I'd carry a radio, and the specific teacher didn't want that and was like, okay, fine. But that's primarily what I spent a lot of my time doing was different aspects of EMS care. To expound upon that a little bit, we had our own EMS group on campus that was a first responder organization, and so we would provide emergency medical services to the campus and the surrounding area. But as part of that, I had leadership and administrative positions, which was different than just being on shift and going to calls and doing all those types of medical care things. It was interesting to be a part of the interaction between the group and the campus administration. And so I learned a lot of professional organizational type skills from that. And then I also had the ability to go to the public level 1 trauma center, go to their ER and shadow physicians, and see a bunch of different cool things there. And then also go out into town and actually ride on the ambulance and treat patients and go on calls and stuff like that. The other big thing that came out of my EMS stuff, and the reason it was so varied for me, and I think I did so much of it, is because I didn't experience burnout essentially, was because I was able to jump around and do different facets of the job within the organization and the EMS side of things. But the biggest thing I really enjoyed doing was teaching. And I got involved with kind of redoing our training curriculum for the organization. I got involved in actually teaching the class that we would put on to train EMTs. I put in like a 4-figure, 5-figure proposal with the police department to teach them emergency medical skills if they were to receive some type of traumatic injury themselves, like a gunshot wound, and how to put on tourniquets and things like that. I would say it's probably not the best idea. I think I did run into burnout a little bit towards the end. But between rugby and then the different facets of EMS and just hanging out with friends and not doing either of those things, I think I did okay. Within residency, I've gotten back to a lot of hobbies I used to have. So when I was in medical school, I lived pretty close to my parents, and my dad started brewing beer, and I learned how to do that. So now I brew beer. I fish a whole bunch. I really enjoy fishing and do that. And then I scuba dive. I learned how to scuba dive in med school, and I do that when I can find the time and get a place to go to do it. And I would say it's probably more important now because I would say I'm working a lot harder than I was previously when I was in undergraduate or medical school. But the one thing I would say to you guys as pre-medical students, whether that be going into a physician role, a PA role, whatever it is do the things that you really enjoy doing, even if you don't see that directly benefiting you getting into X school or going down X pathway. I knew a lot of people, and I kind of fell into the trap to a certain extent of trying to make this perfect application and be the perfect applicant and give the right answers and reading all the review books to find the best school for me with the best grades and answering all the interview questions right. And I would say that I think more so now than ever, schools are looking for people who are diverse in a background sense and an interest sense. So they want people who majored in history, but they did all the pre-med requirements, and they can talk intelligently because that's just something they're passionate about. And yeah, they want to be a doctor, but they really like ancient medieval history. That's their thing. And they also really enjoy going to wine tastings or woodworking or whatever it is. And so I would say that would probably be my recommendation is don't necessarily be like me and do all medicine all the time. EMS I didn't really see as directly benefiting my medical career. And a lot of people told me to back off of it because it wasn't going to be beneficial. And to a certain extent, I kind of said no, maybe a little less politely than that, because it was something I enjoyed doing and it was something I was passionate about. It ended up working for me, and it was something that paid off. But at the time, it wasn't something that I was doing to get into medical school. I was doing it because I enjoyed it. And so do the things you enjoy. Yeah, you got to get good grades. Yeah, you got to take the right classes and the MCAT. I get it. But, be a person too and enjoy the process.
That's really interesting. We were actually talking about that literally last night in one of our meetings. I mean, about the diversity of a student and what building an application should be like from both a personal standpoint and, a work, lifestyle balance standpoint. So thank you.
Yeah, and to add on a little bit, it's something that I wouldn't focus on, but developing those skills of knowing when you're stressed and how to relax. I say a skill, it's a process, it's a feeling. It's really important when you get later into your medicine, and it's so easy to get sucked in because you have a person in front of you who's suffering, and realizing that I do need to step back. I can't be the person right there. Somebody else is going to have to do it. It's very easy in the medical profession, no matter where you are in it, to feel like that has to be you. And it doesn't. You need to take care of yourself too. And so being able to recognize that and have the skills to rejuvenate and re-energize are important and I would say important to start as early as possible.
I think that's big for a lot of the pre-meds, especially those that are, underclassmen and younger, that you need to pick up things that will be healthy ways to relax. I know in college, a lot of people pick up vices that aren't always the best means to relax from schoolwork. So thank you for making that clear, especially from a perspective of someone who's been through it.
Does anyone else have any further questions for Dr. McCarthy?
I just have a quick question for you, Dr. McCarthy. You said in undergrad you have like a 12-hour shift for EMT. Is that correct?
Yes and no. So the campus service I helped run, we would typically do 12-hour shifts. That was for kind of like our entry-level members, what we call a duty crew. I was in it's not really a tiered system. We kind of all helped out, but the supervisor on the calls was called the in-charge. So there was an in-charge and at least one duty crew on at all times, or we tried to have it that way. And the in-charge would actually take 24-hour calls. And so I would have a radio and a pager on me for 24 hours. And if a call happened, you go to the call. And if you're in class, you go to the call. If you're sleeping, you go to the call. Maybe once or twice it happened where I was in the shower. It's like, oh man, all right, go to the call. And sometimes a little longer than 24 hours. And then in the ED, we would typically do 8-hour shifts, occasionally 12-hour shifts. And then out on the ambulance in town, those were 24-hour shifts.
So how did you manage to like balance that with schoolwork and even rugby?
Rugby was tough. I actually I wasn't able to do rugby my senior year, which sucked. But the position, I was the head student position in the EMS group, and the only other person helping run the organization above me was our only paid member. Everything else was kind of volunteer. I got paid a little bit for like the administrative duties, but I think I added up the hours once and it was like less than $4 an hour or something. It was basically just like a thank you gift, which was nice. And I wasn't doing it for the money. But she was the only other person who was helping run the organization, and it took a lot to do it. And I kind of just got sucked into it, kind of like I said, where you feel like you have to be the person there doing it, and it's your personal responsibility. You signed up for this, and a lot of times you want to be that person. That's really where I started to learn that lesson. And I started to, what I look back on now was probably early start of burnout, although I don't really think I hit like rock bottom or anything. But I would say that's probably where it was. And I was probably more sleep deprived than I was in my whole life. I mean, as the head position, whenever there was an issue at the student level with the crew that was on, I had a second cell phone for everybody to call. That was the captain's phone. I was the captain of EMS. And so whenever there was an issue or the lower level people couldn't get a hold of the in-charge, or the in-charge didn't show up at the call, or man, what else happened? Somebody drove a golf cart into a wall. That happened a couple times. Somebody put an EpiPen through their finger. That happened once. Like, I get the call, and then I got to go write up an incident report or do all these things, and it was tough. I mean, I was kind of able to balance rugby, but I wasn't putting a full effort in. I missed a lot of practices. I had to miss some games. Had to be very diligent about my scheduling, and there were times where I would go out to the rugby field to practice, and I was practicing in my EMS outfit, and I just handed my radio and pager to the coach. And he was an awesome guy, really sweet South African dude. And he's like, yeah, I got it, go. And a couple times call would come in, and it's like, all right, got to go. Hop in the truck, go to the call, come back to practice if it's still going. And I don't, medicine is kind of like that. It will require you to make different judgments and different sacrifices to a certain extent. And I started learning that lesson early. I wouldn't necessarily do it that way if I was doing it again, but I don't necessarily regret how I went through it either. Would have liked to sleep more. I would say that. I would have liked to sleep a lot more.
That was awesome. I'm also thinking about becoming EMS. So like, this was like a good like insight to like what could happen. So thank you so much.
It's great. I mean, I think I know a lot of people do scribing, and I think you get a particular look at medicine from that. It's a big upfront time cost to get into EMS, and there's different tiers of EMT you can become. But you see things that are crazy. I mean, I went into somebody's house and bugs were crawling up the wall and on the ceiling. There's some crazy hoarding thing. I've seen people talk with somebody who they went to a call in somebody's car. They went in a toll booth full speed, and they had these concrete ramps in the front of it, and they hit it with one side of their car, and it did like a double barrel roll and then landed on its roof. We had a call just off campus where one of our faculty got hit by a car going like 40 or 50 miles an hour in a crosswalk. And one of my best friends was the first person on scene as the college EMT. And she was pregnant, and it was just like a horrible thing. But he was the first one there. He rode with them all the way to the hospital, which thankfully was like 2 blocks down the street because we're right there at the medical center. We've had multiple cardiac arrest calls on campus that happened, and our out of hospital cardiac arrest save rate was 50%, because that was something that I was very passionate about drilling. Because as college EMTs, we were in a position that we mostly responded to like alcohol intoxications. And it's what it is. It's college. I'm not here to talk about that. But we got that, and we got like ankle sprains and strains from people playing intramural sports. And we were really good at that. What we weren't good at was doing cardiac arrest calls, because they just don't happen that often. And so we drilled and we drilled and we drilled. And one of the greatest moments of that time, and probably one of the things I'll remember forever, was we had, I remember I had a drink or two at the time, and so I couldn't go to the call myself. But I was near my radio, which I would generally just keep on to kind of keep a pulse of what was happening on campus. And we got a call for a person down in an auditorium, no pulse, CPR in progress. And the EMS people from campus went, they did CPR, they got a pulse back, and then he started breathing on his own. And that's like not a very common thing. Most of the time when your heart stops, it's you can't restore perfusion quick enough. That just doesn't happen. But the guy made a full recovery. He's alive to this day, and he had the EMTs who were there at that call to his first birthday party, is what he called it, after he died. And he was like a very wealthy oil businessman in Houston, and it was like a crazy party that he had, and he had these EMTs out to say thank you. He like made a speech to him, and it was I wasn't there for any of that, but I remember one of my friends who was there at that call, who ran the call as the in charge, coming to me and saying thank you. That wouldn't have been possible unless we had done those monthly cardiac arrest drills. It just wouldn't have happened. And so sorry, I don't even remember the original question. Oh, EMS is a great field. You get to do things that you may not get to do ever again in medicine. And it does teach you real skills in medicine and anatomy and physiology. how to talk with people, which is a huge part of medicine, and how to interact with them.
That was awesome. Thank you so much, Dr. McCarthy.
Yeah.
Dr. McCarthy, thank you so much for taking the time today. You taught us a lot of valuable lessons, and I'm sure you've inspired a lot of our members, and you will when it gets posted online as well when other members watch this. Is there a last note that you would like to leave us on for today?
Well, first, if it's okay, I'll type my email and phone number in here.
Definitely.
I'm more than happy to talk with you guys about anything. EMS, medical school applications, military medicine, residency, surgery, whatever it is you guys have questions about, or you want some guidance on, I'm always available and happy to talk. I really enjoy doing this. The one piece of advice I would give is kind of like I hit on, don't just focus on being the perfect pre-med. I saw it work for plenty of people, and maybe that's you, but do what makes you happy more than anything else. And if that's medicine, great, do medicine, but don't do it at the expense of giving up hobbies or giving up relationships with your families or your friends. You don't deserve to be any less happy because you want to be a nurse or a PA or a dietitian or a physician or a paramedic or any of that. You need to do what makes you happy, or you'll end up like me and not sleeping your senior year because you're so involved in EMS and stuff like that. And like I said, I wouldn't have done it differently, but at the same time, it probably wasn't the healthiest thing. It added something to my college experience, but I probably would have backed off a little. And so be a happy individual more than anything else.
Thank you so much, sir.
Thanks for having me, guys. Hopefully this was helpful for you.
Definitely, 100%. So everyone else, I've recorded your names and everything, and you should be good to go for attendance. And Dr. McCarthy, this will be posted online as well. I'll put your contact information there for all of our members to contact you if they would like to talk to you. That's okay as well.
Awesome. Thanks, guys.
Awesome.
Have a
Thank
good
you so
night.
much. Thank you. You too.
Thank you
care,
so
everyone.
much.
Thank you, Dr. McCarthy.
You're very welcome.